we're good to go. So we'll turn the time over to Dr. Duffin.
Thank you, Hardin. Welcome, everyone. There's a couple of people on here that I don't know. And so I think those are Catherine and Lindsay. So
I'm Catherine. Hello.
You can introduce yourself, and then I'll introduce everybody else that we know, because many of us know each other here at the U. But yeah, tell us about yourself.
So I'm a medical science liaison from Gilead. I'm a PharmD. I'm based in Fort Collins, Colorado, and I am looking for projects in the rheumatology space that I could support that involve telemedicine or remote management of patients in rural areas. So I thought I would just listen in today and see if there were any possibilities there.
And you've come to the right place. I think we're going to touch on that.
Okay.
Lindsay.
Thank you.
Lindsay Sweet. And you're on mute. So, and if you don't want to talk about yourself, that's totally fine. You could just say pass. So, and then Shauna, I know you, but I'll make you introduce yourself too. And you're on mute too, by the way. I'll unmute you. There we go. Oh, maybe I can't unmute you. Okay, so
okay, wait, I have it.
Oh, there we go. Now we got you.
Sorry about that. It was pulling up another bubble window. Hi, I'm Shauna Jarden. I'm also a medical science liaison. I'm based out of Arizona. I work for Amgen, and probably the same thing. Looking forward to kind of seeing what the future holds for telecommunications in the medical field.
Awesome. And Lindsay, if you can't make your mic work, that's totally fine. You can certainly put your, okay, there we go. So yeah, so say put in the chat. So also with us, so Cardin Smith and Lisa Smith are administrative people here at the University of Utah that have been supporting this project. I think most of you probably know who I am. I'm Christina Duffin, and Jessica Walsh, who's a rheumatologist, and me, the dermatologist, are the co-hosts, mentors, we call it in ECHO. And I also see on there Luke Johnson, who is our CME referee. Luke is a pediatric dermatologist who is interested very much in telehealth as well. And Dr. Kruger, I think, probably also needs no introduction. He's here to make sure we stay in the straight and narrow in the psoriasis world as well. So one of our superstars in the psoriasis world. And then Jared Price, who's directs our ECHO stuff here at the university. And so thank you all for joining us. I think I got everybody there. So what we're going to do today is just do a really quick overview of this project in a few slides. And then we're going to do a really quick psoriasis overview. And the reason for that is that we expect in the future to have primary care physicians as well as dermatologists and rheumatologists in the audience, and that's the intent of it. And we are working on the marketing of this to that audience. And so this is a starting place, and we have, we obviously still need to continue to work through that to build the audience, and this is true of all ECHOs. And then we're going to talk a little bit about COVID-19 and psoriatic disease, and then we have some cases, and again, to model what the cases are for the future for people to submit. So I'm going to share my screen, and then I'm going to try to monitor the chat at the same time. I've sort of figured out how to do this, but it's still a little challenging. So just stop me if you see something you want me to stop at that point, and just tell me to stop, or I'll keep looking at the chat. So I'll share my screen. And can you see that?
Yes.
Screen?
Yes.
Okay.
Yep.
Very good. Okay. So then I'm going to, sorry, I have to do one other thing before I do that. I have to pull up the chat first. There we go. Okay. Okay. So So what is ECHO? For those of you who joined, don't know what ECHO is, it stands for Extension for Community Health Outcomes. And it's a project that started in the early 2000s from hepatology standpoint, trying to help train, to help educate the community of physicians who are taking care of hepatitis C instead of referring them to centers, which is a burdensome, expensive, difficult problem for states like New Mexico and Utah. So ECHO was started a long time ago. University of Utah was the third replicate of this, and since then we've produced, now I think we're the 10th in the university. Maybe it's not actually that, it's maybe 11th or 12th because we've had COVID ones over the last few months. So Dr. Walsh and I will be the faculty mentors. We're well supported with our marketing group with Cardin and Lisa and Luke. Pac-Man is supporting this. They're a nonprofit that you can see here on the side there that are the Psoriasis, Psoriatic Arthritis Clinics, Multi-Center Advancement Networks. They are all about combined clinics, and Jessica and I had done a combined clinic for over a decade, and this is the next step in trying to bring combined clinics to the community. We've been wonderfully supported by our own ECHO group here, our ONDT office, and our CME office as well. So we'll be able to offer free CME to physicians who want to attend. So the format is that we will be hopefully doing some quizzes and questions and commitment to change or commitment to learning certain things with a set group of content didactic sessions. Those are supposed to be short. This is really a virtual grand round, so a short didactic within cases that are brought by the audience and in some cases by the mentors to discuss and kind of have a back and forth dialogue. And this is the problem that ECHO is trying to solve, that rather than primary care physicians, community specialists sending patients to us, that's Jessica and I, or to go to national conferences, which we can't do right now anyway, but really to bring it virtually and take it back out to the community. And so that's the format. And the future is that we would replicate this at other institutions and then optimize. Telehealth is sort of the last cool thing that we'd like to do, is that we can do multi-specialty consults since we've innovated with the help of our ONDT office, telehealth very quickly in times of COVID. Sorry, a few more builds there. So today, I'm going to kind of blaze through the psoriatic disease introduction because I don't know that we really have an audience that needs to see all of this, but also we'll have this recorded, so if people want to go back and watch it, they can later, and then we'll talk more about psoriatic disease and COVID-19. So psoriasis is an immune-mediated disorder that affects the skin, nails, and joints, but we really know it as a systemic inflammatory disorder that's very complex. The classic distribution is elbows, knees, scalp, but we know that it can be anywhere. And I made this slide for the residents this morning to kind of illustrate that the phenotypes are numerous and they vary by location, severity, and morphology, and they blend together, and patients can have all of them or one of them. Some of them are biologically distinct and others are not. So we have a lot more work to do in this world. Jessie, why don't you go ahead and take it from here for a few slides.
Great. So, and the arthritis piece, as you know, there are lots of different manifestations. The most common that we see is the inflammatory arthritis, and that upper right picture shows a picture of the polyarthritis, and that typically starts in the small joints of the hands and the feet, but it can be anywhere. It can be symmetric, or more often, at least that presentation, it's not symmetric. It's usually just a few joints, and then it may or may not progress into multiple joints. And then the dactylitis usually occurs with peripheral arthritis, but it's different in that it involves the tendon that runs along the finger or the toe, and it looks different in that you've got swelling and tenderness between the joints as well as around the joints. And so those two dactylitic toes are examples. One of the interesting things about dactylitis is a lot of patients come in and they think that all of their fingers or toes are dactylitic because they feel puffy, but I've actually never seen all 10 at one time. It's usually 1, 2, 3 at a time. And then the enthesitis is the inflammation where the tendons meet up with the bone. So just like in the joints, you've got synovial cells at those junctions, and they can get inflamed. Enthesitis, and sometimes you can see it visually, as with this picture in the heel, but most of the time you can't visualize it. But characteristically, it is tender to touch. And it's got to be in the right place. It's got to be where it's touching the bone, not higher up in the Achilles. And if it's not tender to the touch, it's probably not enthesitis.
Next one.
Yes, next slide. Okay. And then the axial disease and psoriatic disease is a really hot topic right now because we're learning quite a bit more about it. There's the spondylitis, which refers to the inflammatory disease in the spine. Sometimes this can look just like ankylosing spondylitis, and sometimes it looks a little bit different, and where there are bulkier syndesmophytes or bulkier bony bridging between the vertebral levels, and it doesn't always occur in the same direction or start in the same locations as it does in AS. And so that's been a big issue with psoriatic spondylitis, is sometimes it's missed because we are not necessarily looking in all the locations in the spine for that. About half of people in general with psoriatic spine disease are HLA-B27 positive, and then there's probably some different genetic phenotypes associated with the different phenotypes. Interestingly, we're also learning that the sacroiliitis, which is the hallmark of what we traditionally think of axial disease with AS, absolutely usually does occur with axial disease and psoriatic arthritis, but up to a third of these patients will have spine involvement without sacroiliitis. So if you don't see it in the sacroiliac joints, it doesn't mean that you don't need to keep looking in the spine if your clinical suspicion is high. So next slide. So comorbidities for psoriatic disease, there are lots of them, and reasons for these comorbidities co-occurring are probably varied. There may be some shared genetic and inflammatory pathways, and some of the most common ones are uveitis and inflammatory bowel disease. We hear a lot about the strep pharyngitis, more even with psoriasis and with psoriatic arthritis. That's probably also true with lymphomas. Depression and anxiety, I think, are getting more recognition because they are consistently quite a bit more frequently found in psoriatic disease patients. Also, tobacco use, depending on the population. We see a lot of metabolic syndrome, maybe even more so in psoriatic arthritis than in psoriasis patients. And sleep apnea, skin cancer obviously is a concern. Fatigue is another very common comorbidity that occurs with psoriatic disease. Next slide.
I'm sure this list is incomplete. There's always things that are being added on, and so I didn't want to overwhelm too many people with too much stuff here, but it's constantly changing.
And cardiovascular risk is also an area where we are learning a lot with psoriatic disease. And we've been seeing for a while that cardiovascular events occur more frequently in people with psoriatic disease. And there's been a lot of effort to figure out, to discern how much of that is because of increased prevalence of these comorbidities that contribute to cardiovascular disease, like hypertension, fatty liver, insulin resistance, etc. And perhaps also some other genetic and shared inflammatory risk that we can't account for with these comorbidities.
Yeah, and I think just another point to make about the ECHO is that this one is sort of an introduction, and each one of these slides could be a full other ECHO, so that's what we anticipate. So we'll go deeper into each of these things in the future. So I'm going to now kind of talk a little bit about selecting therapy before we go into COVID stuff, because we felt like if we had a lot of primary care folks in the audience, they might want to understand kind of better where we're coming from with this, that when we select therapy, limited and localized disease, we'll typically start with topicals, but for patients who have more widespread disease, who don't respond to topicals, who have other difficult to treat areas, et cetera, we often are into phototherapy and systemic agents. And this is a handout that I go over. I call this my menu, or my grid is the other way I put it. And it's a summary of all of the therapies that we offer beyond topicals, and it all is in one place. So I go over this with my patients in clinic and say, these are the things that are options for you, and I write on it and I cross it out. But as you can see on here, there are 11 biologics and 4 oral agents. This is the psoriasis one. We would have to add others in for psoriatic arthritis, because I think what's not on here are going to be things like flutamide and sulfasalazine and the JAK inhibitors. So, and then there's a little bit of reference to effectiveness in the corner for patients. So this is our shared decision-making slide, but you can really see there are a lot of potential things patients could be on if they have psoriasis. So, so I'll jump into the COVID-19 situation, and note these are headlines from the Dermatologic Therapy Journal received in February and March that were very clear just from their title. COVID-19 psoriasis, is it time to limit treatment with immunosuppressants? A call for action, or should we fear for our patients treated with biologics? And I would say that, it's not surprising these got published really early on, but I will tell you that our patients were way ahead of us, and the physicians in the community and in the department were way ahead of us. They were calling me, texting me, writing notes into Epic. What are you doing about patients on methotrexate biologics? Should we stop? Patients were saying, what should I do about my biologic? And then for every one of them, there was probably many more I don't know about that just did it on their own. Because for a long time, we've talked about infection risk and immunomodulating agents. And, if you listen to a commercial, they say that serious infections have been reported on this drug. And so the feeling was that, well, if you see more colds in patients on a biologic, which are also caused by coronaviruses, and potentially more risk of infection, then we might expect more COVID-19 related complications. But really, we had to say to patients, we need evidence, not opinion. We don't really know the answer at this point. And I understand if you stop, but if you stop tomorrow, your risk won't go away, right? You've got to wait until the drug is out of your system, and probably even then some more time. And so that was how we spent the early part of the pandemic counseling people. And so, so just one more aside about ECHO. We don't want to spend the whole hour doing didactics. We want to spend much more of the hour doing cases. But for this particular one, because we don't have cases that got sent in by participants, as we build, we expect that will be more. This could be a full hour and a half going through each of these papers, and there are a lot more papers where for every one of these there's a few more. Like I think I only put 3 IBD papers in here, but there's actually several more that have been published. So these are some of the studies that are now kind of shedding some light on the situation with COVID and biologics. And so the first 3 are focused on populations that include or are psoriatic disease. The NYU publication includes psoriasis, psoriatic arthritis, and other immune-mediated inflammatory disorders, IBD, RAAS. And then there's 2 papers from Italy, and then the other 3 are IBD. So I just wanted to kind of run through them really quickly, and then we can discuss questions as well. And so I have to mess with this chat problem here again. Sorry, I have to, oh well, I'll just leave it alone. So, oh, there we go. The chat box to go away. I can't make it go away. All right, well, I'm just gonna have to figure out what I'm Zoom problem here. Just going to have to remember what I wrote on the slide. Okay, so the first series wasn't the first one published. It was recently published in the last month, which was the NYU experience where they prospectively enrolled 86 patients and followed them. And of those 86 patients that had immune-mediated disorders, 59 of them were COVID positive, and the rest, the other 27, were suspected. And they age-adjusted, looked at comorbidities, adjusted for those factors, and found that that the highest risk of hospitalization was patients who were on steroids, hydroxychloroquine, methotrexate, and not biologics. Now, it was limited because it's such a small study, and they also kind of did some sensitivity analysis looking at both populations of the confirmed and suspected versus combining, or just looking at the confirmed, and really came up with the same thing. And so that study, along with the Italian studies, really gave us a little bit of maybe a sigh of relief that we weren't seeing an early signal here. The Italian studies, the first one there is a case control study where they looked at a little over 1,100 psoriasis patients, of which 22 were COVID positive, with a control population of 54,000, almost 55,000 positive COVIDs of the general Italian population. And their study found that the odds of being COVID positive, quarantined, or hospitalized was higher if you had psoriasis, but not a higher odds of ICU admission or death. And, there's some problems with that study too, because the control population was a general non-psoriasis population. And then the Northern Italy experience, which was a retrospective look at patients with psoriasis, looking at multiple centers, 7 centers. They had a little over 5,200 patients with psoriasis, found no deaths, 4 hospitalizations, and no statistical difference compared to the general population in complicated course. So those 3 studies kind of made everybody say, wow, that's, we can kind of breathe a little bit of a sigh of relief to say, well, early observational studies were not showing us a big signal, with limitations. And then if you look into the IBD literature, a few other nuances, which I think are interesting, because then those patients tend to have more immunosuppression, right? They're often on TNF inhibitors or IL-23 or IL-12/23 inhibitors with other immunosuppressants like sulfasalazine, for example. And what they found from that, kind of the same idea, that doesn't seem to be an increased risk of severe COVID just related to having IBD itself. It always boils back to age and comorbidities. And that was the same in the psoriasis population. And the things that they saw risk related to were chronic steroid use, more than 2 comorbidities, and then other drugs like mesalamine and sulfasalazine, but not TNF inhibitors, so not the biologics. Same kind of story with the retrospective cohort study by Singh and the VA study by Khan, that there did not seem to be a signal there with the biologics, and the same kind of things were happening with comorbidities. And then the one other thing I found from the IBD group was that they tend to present with more GI symptoms, which makes sense. But that was another kind of interesting finding. So that's sort of my kind of brief view, and then Jesse's going to go further into some of the other studies. And then just, I think this is my last one. Yeah. So my last one is that many of the patients in some of our organizations ask, well, will it flare with COVID? Because it's a virus, right? Psoriasis tends to flare with stress and viral infections. What about the drugs that we're using to treat COVID? And we know that, there's at least 2 case reports of patients' psoriasis flaring, and one of them does appear to be potentially related to hydroxychloroquine or potentially steroids that were being used. And those are things that dermatologists and rheumatologists know about psoriasis, is that there are things that flare psoriasis. Those are systemic corticosteroids, hydroxychloroquine, an anti-malarial, viral infections and stress. So those are kind of take-home points for the group to remember. Those are the things that flare psoriatic disease in the context of COVID. Oh, and PPE behind your ear, right? So hand washing.
Yes.
Okay, so Dr. Walsh.
So I'm going to go a little bit more in depth into articles that I have found to be particularly interesting and relevant, specifically related to the medications that we use for psoriatic disease and other rheumatologic and dermatologic diseases. And this study was done by the Global Rheumatology Alliance, which is a physician-reported registry group, and it included 600 patients with COVID from 40 different countries. And do you mind clicking the next couple? I think there we go. And you can see the distribution of rheumatic diseases here. The psoriatic arthritis represented about 12% of this population, whereas most of them were rheumatoid patients. And interestingly, not everybody had available data with the disease activity, but about 80% were judged by the clinician to be in remission or to have low disease activity. Next slide. And what they found is similar to what we've seen with other studies, in that people who with older age and with comorbidities, particularly lung, heart disease, and renal insufficiency, had higher risks of being hospitalized. Next slide. And then they looked at the medications that patients were on at the time that they got the COVID infection, and they grouped them into those who were on conventional synthetic DMARD only, so that would be the methotrexate, sulfasalazine, leflunomide, etc. And they didn't see any, and they did some adjustments to account for differences in populations, but they didn't see any differences in hospitalization rates or risk in patients who were on the conventional synthetic DMARDs compared to people who were not on a DMARD. And then they grouped together patients with biologic DMARDs and with the JAK inhibitors and Otezla. And there they saw that those patients were at lower risk for hospitalization. And then when they grouped these together, there wasn't much of a difference. NSAIDs didn't see much of a difference either. And then the steroids, again, the story there is similar to what we've seen in the IBD and other literature. But in terms of higher doses of steroids being associated with a higher risk of hospitalization in these rheumatology patients. Now, interestingly, they didn't initially intend to report or to break down the groups any further, but they did do a sub-analysis where they looked at TNF inhibitors specifically, and they had a lower number of cases, so this was only 56 cases, but the patients who were on a TNF inhibitor were less frequently hospitalized, so the risk was lower with a TNF inhibitor than on patients without. So next slide.
Sorry.
I think I just did that.
Okay.
So that's the summary right there, the take-home message.
Right.
So lo and behold, there's this dexamethasone study that comes about, and all the other studies we've been looking at so far suggest that glucocorticoids are associated with worse outcomes with COVID. And then this dexamethasone study was an all-comer, so it wasn't just rheumatic disease or psoriatic disease patients. And it was a large randomized trial of about over 6,400 patients, and it was open label. And the patients got about 6 milligrams per day for up to 10 days. The duration was shorter if the patients were discharged from the hospital before 10 days or if they died. And the dexamethasone 6 milligrams is about 40 milligrams of prednisone. And what they broke this down in terms of what type of respiratory support the patients required. If you look here, you can see that about a quarter of them in the patients who received the dexamethasone versus those who were randomized to usual care didn't require any oxygen support. About 60% required oxygen, and then roughly 15% required mechanical ventilation. Randomization demonstrated that the randomization worked. The comorbidities were similar in both groups. Next slide. The meat of the outcomes. They demonstrated that with dexamethasone, the overall survival was better in patients who received dexamethasone versus patients who were randomized to usual care. And you can see that, that the mortality in the usual care was almost 25%, or it was 21.6% in those with who received the dexamethasone. Now, when they broke that down into subgroups according to level of respiratory support that was required, the patients who required mechanical ventilation, so the 15% or so, had even a more pronounced benefit or difference with the dexamethasone compared to the usual care. So usual care, 40% died versus 29% with dexamethasone. And with oxygen, there was also a benefit damage associated with the dexamethasone. Interestingly, in the patients who did not require any oxygen, there was no statistical difference, but maybe even some hints that they didn't do as well. So that's raised some question about need for further analysis in terms of which patients should glucocorticoids be considered for. Next slide. This kind of brings us back to the questions, are steroids good or are steroids bad with COVID? And I don't know that we have the answer. The authors in this study pointed out that the timing of the dexamethasone administration differed between the groups of patients. So the patients who did not receive oxygen, who did not appear to get a benefit from dexamethasone, received it after 6 days of what was believed to be the beginning of their infection. The patients who with oxygen only received it 9 days later, and the group who benefited the most, the ventilated patients, got dexamethasone on average 13 days after infection. And so with the authors, they noted that viral replication with COVID-19 occurs quite early after infection, usually within the first several days. This is earlier than many other infections, including most influenza. And the immunopathology, or the cytokine storm that gets people into trouble, tends to occur later, usually at least after a week after the infection occurred. And so their hypothesis is that the timing of the steroid may matter in terms of outcomes. So the rheumatologic patients who we've been looking at with other studies who are not doing well on steroids, it looks like they got their infections while they were on steroids. And these dexamethasone patients, they received dexamethasone later on in the course of the disease, presumably after their peak viral replication decreased and their immune systems were kind of driving the show with the pathology. Now, of course, there may obviously be differences between rheumatologic patients and psoriatic patients and dermatology patients compared to the general population which this study represents. But these are things for us to kind of think about, and I'm guessing we're going to see more research on this. Next slide, please. And I just want to say one thing about IL-6 inhibitors, because in the guidelines, they're being treated differently than other biologics, and it makes sense because IL-6 goes crazy and elevates in people with COVID-19 and with other types of acute respiratory failures. And this data is from an observational study. They did inverse probability weighting, propensity matching, so a lot of statistical manipulation, which I think is a great study, but a little bit less conclusive. I think we have to be careful with looking at it, but it does give us some hints and and helps us feel a little bit better about some of the recommendations that are being considered. And that's the idea is that tocilizumab in all comers, again, this is not a rheumatologic or dermatologic population, but in all comers, people who received tocilizumab had lower fatality rates, and they slice this data several ways, but you can see that that here the mortality rates at 28 days, I think, was their primary outcome was lower in people who received tocilizumab. They did, though, find that people who received the tocilizumab had higher rates of superinfections. So these were mostly bacterial pneumonias, mostly staph infections. But they didn't appear to be dying from these superinfections. So the death rates were not higher in these tocilizumab treated patients versus those who were untreated. Next. There, this sums it up, I think, pretty well. It's observational, but they did better. Next slide works.
Yeah.
Oh, can I ask a question? This is Jerry Kruger.
Yeah, go ahead.
The 28-day looks like an endpoint that was arbitrarily established. Is it that you just prolong the course of the illness? And if you waited for 35 days, it would look more like it does if you didn't go on dexamethasone.
Yeah, so that's an interesting question. And if you kind of look down the differences appear bigger in the shorter day follow-ups. And so that's, but they did look at patients who were discharged alive. And so that's regardless of how long it took them to run their course, or at least the course of their acute phase, acute illness of their COVID. And it still looks like the people with tocilizumab did better. So I think it's a good point to say, gosh, maybe they just delayed the bad outcome. But my interpretation of these data and other data are that there were true differences.
So I guess was the end of follow-up was 28 days, or the end of follow-up was when they either died or were declared cured?
Died or discharged, or yeah, so died. Some of the discharged ones, I think they still tried to follow up as other measures. I don't think their follow-up was perfect, though. I don't know the exact numbers of how many patients they were able to follow up after they were discharged. But presumably, if they were discharged and got sick again, they would end up, they would have been able to capture most of that data, I would guess. But it's possible that they could have been discharged and then died, and then we wouldn't know their outcome.
Thank you.
All right. So I wrote the summary slide. So Jesse, you can weigh in and decide if you agree with this approach. This is part of the fun of this, is the back and forth of it, I think. And Dr. Kruger, you could certainly jump in too. But, you know, to my eye, for what we have now, which are mostly early observational studies, and COVID, they don't suggest an increased risk related to biologics, and perhaps there's even a protective effect, but again, I think it's too soon to say that. More studies are needed. But comorbidities of celiac disease, which are a well-known problem in our world, do stand out still as the issue of increasing the risk of COVID-related morbidity, mortality. Dexamethasone and tocilizumab might be effective with the caveats that Dr. Walsh mentioned, and that I think any clinician who is treating these patients needs to be aware of the risk of chronic steroid use and COVID-19, the potential risk of dexamethasone in psoriasis for a potential flare. But I think that if they're on a ventilator in the ICU, it's probably worth the risk to do that. And then hydroxychloroquine in psoriasis. It's an uncommon but issue in it, but it can potentially flare psoriasis. I've probably only seen maybe 2 or 3 cases of that in my life, and maybe Dr. Kruger and Dr. Walsh can weigh in on how many they've seen, but we put it on the list of risks.
I've only seen it once in a patient who had thought to have discoid lupus, but actually had psoriasis and was put on.
Yeah, that's almost exactly this.
And got worse.
Yeah, I had a similar experience with a different patient who was thought to have lupus and had a new rash form, and then they thought it was the lupus, and they upped the dose of the hydroxychloroquine, and it got worse. And then I saw them and said it was psoriasis. So we see lupus and psoriasis together in people sometimes. So
I don't think I've seen it.
So I'm assuming that the brave and the bold, the guys who are admitting people to intensive care units, you know, from my perspective, getting intubated is sort of a sign of it's time to make sure your will's signed and you've got a place to go after you die. So early intervention seems like is with tocilizumab and dexamethasone is important. And I bet that people who run intensive care units are shifting their emphasis on when they start therapy to a lot sooner.
Yeah.
And that's why I'm hearing that, you know, death rate is not quite as bad as it was initially. Do you think that's the case?
I don't know. I don't know how widespread these practices are yet. I think steroids are getting used more. This hypothesis that too early could be bad is a really curious one, because obviously you don't want to wait until your patient is
Right.
too. And I was trying to do a little bit of searching on whether anybody's trying to quantitate viral loads and use that to guide. I mean, so far I haven't been able to find that, but I'm guessing it's. I'm guessing people are thinking about it or trying to figure out how to study that, because if that hypothesis has any merit, it'd be tricky to figure out when is the best time to do it.
yeah, that's interesting. I mean, we certainly are aware of this viral replication issue with zoster, for example, or herpes simplex, right? And so we don't bother giving people antivirals if they have had their disease for several days. And steroids are sometimes, topical steroids are commonly used, but again, sort of as a late, it just reminded me of that same kind of treatment paradigm that we have, again, off-label idea of using the antivirals very early when viral replication is happening, and then later you add in some steroids for the inflammatory component.
So what's the story on the JAK inhibitors with COVID-19?
So Dr. Haberman's study included biologics and JAKs kind of as one group, and didn't see a signal, but that's really kind of getting down to a really small number of people.
Yeah, so the odds ratios that I've seen in various studies they're similar, but again, the numbers are so small.
Yeah.
CR just updated their COVID recommendations on July 13th. And just about every recommendation says, there's a caveat at the end that says, we don't know with JAK inhibitors. So they don't really want to comment on it yet. So I don't know that anybody feels very comfortable.
Well, certainly
Theoretically, they could be helpful. But
but yet in clinical trials for rheumatoid arthritis, but mostly for psoriasis and psoriatic arthritis that I'm aware of, Xeljanz, that particular study, we had 6 times more herpes zoster in that cohort than we did in the placebo group.
Yeah, I think
that shifted my mind over to getting a JAK inhibitor is not going to help your viral illnesses.
Yeah, I mean, I think it's a concern, but I think I'll just take it straight back to COVID has, made us fall flat on our face making assumptions. And so I think we have to get more data before we decide that. And so, right, and that's sort of the point, is that things that we expected early on did not pan out. And
yeah, and I think there's a little bit on just the way the virus enters the cell, and inhibiting JAKs may theoretically be helpful in terms of making it more difficult for that to happen. But I think that's theory. I don't think we have any data to support that. And then this opposite clinical experience with a different virus, I agree is reason to think